is Cassandra Romas, and welcome to 30 Medical Minutes. When men pass the age of 40, they often become aware of their prostate glands and begin to notice health problems that arise with this important part of the male reproductive system. An increase in the frequency of urination may be the first symptom to cause concern, but a routine physical exam may bring a hidden problem to light. A blood test called the PSA may be the first sign of prostate cancer, the most frequent form of non-skin cancer in men, a cancer that even today is the cause of many deaths. Our guests today, Dr. Domenico Savatta and Dr. Alan Krieger, are urologists and attending physicians at Overlook Medical Center in Summit, New Jersey. They are going to discuss prostate cancer and its symptoms. They will describe the battery of tests and the army of treatments that are presently available. They will also bring us up to date about recent advances and issues in connection with prostate cancer. This subject is important to men and to those who care about them, so please stay tuned. Welcome to Dr. Savatta and Dr. Krieger to 30 Medical Minutes. Welcome, gentlemen. Thank you so much for coming.
Thank you for inviting us.
Thank you very much.
Okay, before we start with our topic, let's learn a little bit about yourselves. If you could tell me a little bit about your background and your practice, that would be great. Dr. Krieger.
I am a urologist practicing for almost 24 years. I'm board certified. I'm also the president of the Urology Group of New Jersey, which is a group of 28 urologists throughout New Jersey.
Okay, and Dr. Savatta.
I've been in the area about 10 years after training at Indiana University. I'm also a urologist, but I specialize mostly in urologic oncology, which means prostate cancer, kidney and bladder cancer are my subspecialties that I deal mostly with.
Okay, wonderful. Obviously, I'm talking to two wonderful experts here on, and our topic today is prostate cancer, but I thought before we talked about prostate cancer, we would just define the purpose of the prostate. What is the prostate? And what is its function? Dr. Krieger.
Very good question. The prostate is considered a sex gland, and it's located right at the base. Here's the bladder, and it's located right at the base of the bladder. And as I explained it, the bladder is very much like a funnel. It collects the urine, and we urinate the urine through the urethra, and that would be the neck of the funnel. And the prostate sits right at the base of the bladder like a donut, and can cause symptoms, which we'll discuss later on, as far as the urination and a man's ability or inability to urinate. So the prostate actually forms liquids that help the transport and the viability of sperm in a man.
Okay, fine. So obviously it's a male organ, it's in that location, and it is part of the reproductive system.
Yes, it helps in the keeping sperm alive in its transport, again, for fertility reasons.
Okay, very good. Okay, so apparently this gland does get cancer. So Dr. Savatta, could you tell us exactly what prostate cancer is?
Yeah, sure. When you hear the word cancer, everybody takes a step back, and really all cancer is the cells that are normally growing in any organs basically grow faster and they're not regulated. So prostate cancer is these cells in the prostate that Alan describes to us grow more frequently, and the growth of those cells in an abnormal fashion is prostate cancer. So if we can get over the emotional impact of cancer to all of us and try to focus more on each of the different cancers, fortunately prostate cancer is a slower growing tumor than most cancers we're familiar with.
Okay. Is it a tumor within the prostate gland?
Microscopically, it is a tumor in the prostate gland, which means the way prostate cancer usually forms is it grows as small cells and small tumors. With the naked eye, we often can't see them. And often with the finger exam, we often can't feel them. But it is a growth in the prostate that will grow.
Okay, fine. All right, and you said that it could be slow growing, and it could, obviously in that case, grow beyond that. And that's when it becomes a far more serious thing, I presume.
Right. The treatment of all cancers is really to try to find it when it's early on and hasn't grown or spread outside the confines of the prostate. So the slower growing cancers often stay in the prostate for many, many years and decades.
Oh, wow.
And the faster growing prostate cancers can stay within months or a few years, but eventually will spread outside the prostate. And the more aggressive ones tend to cause death eventually and major disabilities prior to death. So as urologists, our goal is to find out if there's cancer or not, and is it a more serious type or a less aggressive form, and then treat it appropriately.
Okay, fine. And who gets this prostate cancer? Are there certain groups or types of people that do get it more so than other people, Dr. Krieger?
Yes, there are. And one of the most important things that we know throughout the last 20 to 30 years really is genetic testing. We know that there's a higher incidence of prostate cancer if it's within the family to begin with. So that's a very important group within the population. As men get older, there's a greater chance of prostate cancer being within the prostate. That's why there's this saying that many men and families are familiar with. Men will often die with prostate cancer, but not of prostate cancer. Sometimes that does hold true. And some studies done many years ago showed that as we get into the 80-year-old age, there's an 80% chance of cancer being identified within the prostate. Many years ago, we used to think it was 1 in 11 men would get prostate cancer. We now know that it's 1 in 6 men, and in African American men, another high population that contracts prostate cancer, it's 1 in 3 men. So as we get older, family history, African American men. We also know that in the underserved areas where men can't be screened, there's a higher incidence of prostate cancer that's found. And when there's lack of access to quality health care, where men don't have that available to them, those men have also found to have a higher incidence of prostate cancer.
That really seems a shame to me, because you're saying, primarily, Dr. Savatta, you're saying that it could be very slow growing and people can die with cancer in the prostate and not have adverse effects from it. Something else will cause them to pass away and not that itself.
That's right. We do know that there are over 30,000 specific cancer deaths in men only from prostate cancer alone. So as you mentioned beforehand, even though the saying is you may die of something else and not prostate cancer, we do know definitely that men have died from prostate cancer. What we also know is that we have decreased that death rate by almost 40% in the last 15 to 20 years because of screening, because of good diagnosis, and because of treatment of prostate cancer in men. So we have come a long way in the treatment of prostate cancer.
Well, that sounds wonderful. And you mentioned that screening and testing is important here. So why don't we outline what sort of tests are routine and what sort of tests are necessary to come to a diagnosis of prostate cancer, Doctor?
Thank you. There's 2 basic reasons why men want to think about prostate cancer. The first one I want to start with is just if you're having any symptoms, where it's not really a screening for prostate cancer, and if men have a symptom that may be attributable to prostate cancer, that's different than a man who's 43 years old and healthy and no other issues, and that would be screening. So if a man has any kind of blood in the urine or any kind of sexual problems, or they're not able to function properly, if they're having any kind of increasing urinary problems, those are symptoms that can be linked to prostate cancer, and then we really want to do a screen for prostate cancer in these men, and that would consist of a PSA, which is a simple blood test that we order. Man has a blood draw, and we get the result back, and that gives us an indication if they're more or less likely to have prostate cancer. Equally important is an examination where we do a rectal exam on the patient, and I know most men don't like hearing that or thinking about that, but it's equally important to the blood work, and between the blood work and the exam, we have a good idea of their probability of having prostate cancer. The other bigger issue we could probably discuss more later is screening for asymptomatic men with none of these symptoms that come in and say, I'm worried about prostate cancer. And then those men are broken down into the risk categories that Alan discussed, and also men that have no family history and no concerns.
Okay, so I'm getting a story or a picture here that you can be an elderly person and begin to show symptoms of frequency, urination, you have to get up during the middle of the night. That other symptoms would be that they get this. Well, I wouldn't know, but I've read that you said that they feel that they can't empty their bladder out all the time,
Right.
and other symptoms in
The
that
symptoms,
nature.
yeah, the symptoms can mimic a very common disease in men known as BPH, or benign prostatic hyperplasia. And that starts usually in men between the age of 40 and 45, and it could be a slowing of the urinary stream. It could be having to wait a while to get the stream started, waking up at night, and as you mentioned, also not being able to empty the bladder fully. That's why when men have symptoms, they should get checked by their medical doctor and a urologist to differentiate between a benign process or potentially a malignant process. So the PSA stands for prostate-specific antigen, is a blood test, and we do know it can become elevated in a man who becomes older and as the prostate grows larger. It doesn't necessarily have to be related to prostate cancer. We do know also that the PSA, the blood test, can become elevated in 3 very common processes in a man. Prostatitis, which is an infection of the prostate, BPH, benign prostatic hyperplasia, which is benign enlargement, and prostate cancer. If a man has instrumentation or an exam of the prostate or a biopsy of the prostate, and then they decide to get another blood test immediately afterwards, it will be falsely elevated. So the digital rectal exam, the DRE, which is an exam of the prostate that we perform, and the PSA combined together increase our opportunity to try and detect prostate cancer. So it doesn't necessarily mean that a man's prostate-specific antigen absolutely indicates prostate cancer, but we do know that the higher the level goes, the higher the chance of prostate cancer, and the speed at which over time, called the velocity, that the PSA increases is an indication of there possibly being a prostate cancer within the prostate.
That's very interesting. So once again, getting back to what I was just saying, I'm getting a vision here of a more elderly gentleman who's beginning to show the symptoms that you were talking about, and then perhaps a much younger gentleman who's beginning to manifest these same symptoms. Are you telling me that if somebody is showing these symptoms when he's in his 30s or 40s, not even quite 50, that he should definitely seek your an exam, a screening or something, because the indications are a little bit more likely that there would be a problem?
I think that's a good assumption. I think also that you want to make sure that it's not anything worse, such as a cancer, and that it's a benign process going on. I think any time that there are symptoms in whatever disease process, the person should get checked to rule out what may be going on in that organ. Okay.
So you're talking about screening as being one of the most important tools that we can have, as you as physicians can have, in determining whether it's benign, whether it's an old age development, and or the more serious situation of prostate cancer. Sounds like it's a pretty routine, easy exam to have. It's just a little blood exam. It's not invasive. It's not going to hurt anybody. I'm detecting that there's a problem here with the PSA screening, and that you have concerns about that. Would you like to talk to me about what's happening in the medical world about PSA screening?
Yeah, before I get to the PSA screening, just the last point about a young gentleman who has those symptoms. When you have
Yes.
those symptoms, that's not true asymptomatic screening. And with young men that may have prostate cancer, it's much more important for us to figure that out, because if something may hurt you in 20 or 30 years and you're 80 years old, it's probably not important. because you'll be 100, 110. But if somebody's 40 years old and something may hurt you in 20 or 25 years, that's very important to catch. So those young men with those symptoms really are the ones that really want to target to say, please go see your urologist, get testing, and make sure that you don't have anything serious. And that's the symptomatic patient, the young patient. Now, as far as screening, the big debate that started a few years ago is the government task force that was made up of non-oncologists and non-urologists. Pediatrician headed the force, came up with a recommendation that, looking at the evidence, the morbidity in the treatment of prostate cancer, meaning the incontinence that may develop and other side effects, wouldn't warrant routine screening for asymptomatic men. So the conclusion of the panel, basically, their recommendation was, if you're asymptomatic and there are no symptoms, there's no need for any testing, no rectal exam, no PSA. And the main point was the PSA wasn't the perfect test because there are false positives and false negatives, and the data they looked at was 20 years old. So the truth is, if you look at today's data and how we diagnose it and treat it, I think it'd be a very different conclusion. And the other problem with prostate cancer is, if we said it may not hurt you for 20 years, if somebody may have prostate cancer and live 10 years, that's good, but that's not the end of the story, because you have to wait really until they die of something else or die of prostate cancer. And the scary thing, me sitting here, or Alan sitting here, we have a 3% chance of dying of prostate cancer. Being urologists in this current climate, there's still a 3% chance of a man dying of prostate cancer. So to really represent the facts accurately, we have to have a much deeper understanding of why they made this recommendation, and really what does it mean to the individual man that wants screening and may have a concern for screening. The other concern is the media now has taken this conclusion, and the way a lot of the patients now come to us saying, well, prostate cancer, that's not important. I read that you don't have to worry about it. That's not what they said. That is what some of the media says, and that's even more dangerous, because they take the headline and they don't really understand it, and they translate it a little bit, and by the time it gets back to the patient, there's almost a concern that, why would you want to test me at all for any reason? So even if I have symptoms, I don't need to have that testing. So we want to really get the message out that every case is individualized, every case is different, and certainly if you have a right as a man to bring that to your doctor, your primary care doctor, your urologist, and have a better understanding of, should I be screened, and what does this mean to me if I have screens, and the negatives and the positives of getting screening.
Okay. I'm going to take what you said, and I'm going to emphasize what you've said. You're telling me that there was a government task force made of physicians, but not urologists, not oncologists, who've come up with a recommendation of saying that it's not necessary to have PSA testing, screening for prostate cancer, probably because it seems to me that because the incidence of prostate cancer has gone down so much, and probably because of the results of the PSA screening that you've caught so much. So they're saying that PSA screening isn't necessary anymore, and so therefore an individual, a patient, doesn't have to have that concern. And you're saying that's basically in itself a false positive, because the concern is there, the incidences are still there, and of course the beginning stages of prostate cancer are asymptomatic, is what you told me. You don't know that you have it, but if you caught it in the very beginning, you can cure it, get rid of it, and you should be in a much healthier state for a long period of time. Am I getting it right?
Yes, that's absolutely right. Over time, the numbers, the incidence, how often it occurs, has remained stable. But we have seen in the last 15 to 20 years that we've had a tremendous impact on the death rate. And the death rate from prostate cancer has decreased almost 40%, and that's tremendous. The PSA is an informative blood test. It doesn't mean a man has to go for treatment. It doesn't mean a man has to have radiation. It doesn't mean that a man has to have surgery and have the potential side effects of all those treatment options. Now, we used to call it watchful waiting. We now call it active surveillance, which means we can watch a person with cancer throughout their life and then make a decision at a given moment to either intervene or to continue to watch. And there's new innovative therapy that we can also use very much in such as other organs, such as what we call focal therapy, which is just killing the area of cancer within the prostate. So the most important thing is to have an open dialogue with your physician, What's my advantages? What's my disadvantages? Do you want to know that you have cancer? Now remember, years ago, people wouldn't even speak that word in their house. It was taboo because if you speak it, everyone else gets it. Now with the media, social media, and everyone coming in the public light and saying, I have cancer, let's talk about it, you have a dialogue with your physician, and then you have a plan of treatment. What the government did in 2009, the U.S. Preventive Services Task Force said, with old data, you don't need to screen, because if you get screened and you have cancer and you have treatment, do you want to be impotent, incontinent, and all these other side effects? And that missed the mark. The mark was detect a cancer and have an open dialogue with your physician. What would you like to do about it? Don't deprive a man's ability to seek out health care and especially diagnose a cancer. Don't take that away. That's a man's right. And it's the commitment of us as urologists to have with the patient and say, you're at risk because of these reasons, or you're at lower risk. But at least have a dialogue and get men involved with their health care. To women's credit, they're very involved in their health care, and there's so many advocacy groups for breast cancer, for ovarian cancer. And with men, it's kind of in the backlight of where we see men's health. And we need to bring that to the forefront of healthcare.
That's a very important message that you're both making today on the show, and I appreciate that. I'm going to repeat what you've just said. The PSA screening may reveal that you have cancer or reveal that you don't have cancer. But if it reveals that there is a cancer in the prostate, you're telling me and you're telling our audience that it doesn't necessarily mean cancer automatically means treatment. What you're saying is that with this new word, active surveillance, that you are going to have a dialogue with your patient to decide what is the best course of treatment, which may be nothing.
That's right.
But watching.
That's right. So using the PSA is an indication for a man to seek out an opinion of a urologist and to undergo a procedure called a biopsy. And the biopsy takes a sample of tissue that gets sent to a doctor, a pathologist, to be analyzed to determine if there is or is not a cancer present. One of the greatest ways now that we can sit back and have a conversation with a patient and then say, you have a very aggressive cancer, or you actually have a very slow-growing, maybe even indolent cancer, is some of the new genetic testing that's being done on prostate cancer to help aid us in that decision to have a discussion with treatment or not treatment.
Okay. Well, this has been very informative, and it's good for us to know that. Now, why don't we outline some of the treatments that are available? What are they? Dr. Savatta.
Whenever a man gets diagnosed with prostate cancer, we always start with several factors, and one of them is the life expectancy of the patient and their overall health, and the type of cancer they have. We judge by the Gleason score and the PSA, and then we outline different treatment options. We always go over all the options and then tailor to the individual patient. But number one is the active surveillance we always start with, because if there's a good chance your cancer is not going to hurt you in your lifetime, active surveillance may be the best option. And we have a whole protocol on when you have to have repeat biopsies and blood work. Then there's a whole host of different forms of radiation that we can target the prostate cancer and target only the gland. And the side effects that always were there with bladder problems and rectal problems are still there, but they're much less than they were 20, 30 years ago, or even 10 years ago. Then we have a whole host of types of different surgeries, and all of them basically remove the entire prostate. When you want to treat the prostate cancer, usually surgically you want to remove the whole thing, because one, it's easier to do that. Number two, removal of the prostate gland, all that really does is makes you unable to have children. But all the horrible side effects that men have with prostate cancer surgery isn't from the prostate itself, it's from the organs around the prostate, the sexual nerves that cause erection problems, the urinary muscles that cause urinary leakage problems. And fortunately with surgery, most of these side effects go away if men are healthy to start with, and if the cancer is caught early. If I catch a man with very early cancer, I can do a very accurate surgery and leave all the extra tissue.
Okay.
If I have it more advanced, I can't do that. So even treating somebody that has more advanced cancer that may still be curable are going to have more of those side effects people are worried about than if I catch it much earlier.
Okay. Oh, by the way, are we talking about when the cancer is still contained within the prostate and hasn't metastasized?
Sort of. If we have a prostate, a very small focus in the prostate, I can remove the entire prostate very accurately in just the prostate, nothing else outside of the prostate. If, though, we have prostate cancer that's going extensively towards the capsule of the prostate or towards the edge, even though it still contains to the prostate, I have to get a little bit better margin off the prostate to make sure there's not a stray cell that goes into the nerve area. And the erection nerve's only a few millimeters away from the cancer in general. So if I got a guy that has only a very small area who's very young, his chance of getting his potency back and having normal erections is over 90%. If I have a man that has maybe a lot of cancer still in the prostate, we don't know for sure until after the surgery, so I have to do an operation in a certain way to take out some of those nerves. It may only be 50%. And the other thing when we talk about surgery and the advances, traditionally we did open surgery that's been around for 30, 40 years, and that involved an incision between the belly button down to the pubic area, and then we went to laparoscopy about 10 years ago. And about 9 years ago, I started doing robotic surgery, which basically means we're doing the same surgery, removing the same prostate, but we do it with little small holes like laparoscopy, and then we have a special robot that we actually have to hold our instruments, and the robot holds my 3D camera and it holds 3 other instruments. So I'm able to operate next to the patient and be very comfortably sitting down looking into a headset and see everything in 3D with 10 times magnification. So the magnification difference between having me sit down next to them versus doing with open surgery and magnifying loops, it's about a 50 times different magnification. So those important nerves and blood vessels and muscles, I can see them much more accurately. And with the robotic surgery, the side effects that the task force were very concerned about have dropped dramatically, and the ability for the patients to get back to work and out of the hospital have increased dramatically.
Wow, I'm just amazed. You're talking about you're doing surgery robotically with equipment that can allow you to be so precise that you're going to minimize the side effects for the patient, and that you have millimeters of precision there.
Yes.
That's fantastic. You know what? Our time has passed. I want to thank you both so much for this very enlightening overview of prostate cancer and the incredible robotic surgery. And thank you for joining us today on 30 Medical Minutes.